Today I'm going to be talking about cardiovascular changes in geriatric patients. So for starters, some very common aging changes that occur in the cardiovascular system. For one, there's average a decrease in cardiac output of 30% to 35% by age 70. So that can be pretty important information just because with a decrease in cardiac output, there's a decrease in blood supply to the body, therefore less oxygen being supplied to the tissues. With the thickening of a heart valve, that can lead to the valves not fully shutting and blood backflowing into chambers that they should not be. With the increase in peripheral vascular resistance, that can lead to just an increased blood pressure there because the heart's pumping more against the resistance, therefore increasing the pressure against the artery walls. And with the decreased strength and elasticity of blood vessels, this doesn't allow them to dilate and constrict as well. So, like in the veins, the valves might not close as well as they used to, causing a backflow, causing venous insufficiency, or in the arteries, just build up on the plaque or build up on the walls with plaque and stuff can cause pressure to build up in those arteries. Some more changes. So, a decreased ability to respond to physical and emotional stress. So, just stressful events and anything with a weaker heart and like less cardiac output, it won't be able to supply the body with all the oxygen it may need, which is also relevant to the exercise part aspect of this, which the heart rate might take a little not longer to return to normal after exercise. With that decrease of cardiac output, it's supplying less oxygen, so it'll have to make up for it after they're done exercising. And also the loss of strength and efficiency of the cardiac muscle, that just leads to a less effective pumping of blood throughout the body, which is also related to the decreased cardiac output. And then finally, the decreased arterial wall elasticity, which, as it says on the slide, leads to isolated systolic hypertension. So that's basically where the systolic blood pressure reading is over the recommended limits, while the diastolic may be low. So there's kind of a larger range in between the two numbers. So for assessments that you want to make sure you get with a geriatric patient, first of all, as with any patient, a thorough history, just to understand any medical problems they may have going on or any kind of medications they're on that may affect their cardiac health. And also an oscillatory gap. So that's basically when the second heart sound may skip or not be there, and it may be gone for a period of time, but then it'll come back for a short period of time, and then it can go away again. And that's just something to look out for when you're taking a blood pressure reading on a patient, because that can cause their blood pressure to be abnormally low than what it actually is. So that's not something that's generally found in younger populations, so it's something to keep an eye on because you may not even think about it, but it's something to consider. That way you make sure to get an accurate blood pressure reading on these patients because that's a pretty crucial reading to get. More assessments to do. Obviously, frequently monitoring vital signs and kidney function. For the vital signs, you just overall indicator of how the patient's doing and just making sure that their vital signs are within a range acceptable for them. And kidney function, that can be very important because as the heart begins to pump out less blood or their cardiovascular system becomes less efficient, the kidneys may be getting less blood, which may cause them to start not working as well, going into renal failure, which is obviously a huge deal with fluid and electrolyte balance, and also patients on medicines like digoxin or any other kind of cardiac medicine that can cause them to have that medicine be in their system longer, and you can easily overdose them on that and cause a toxicity through that. And also, you just want to review past blood pressure readings after you get your initial one, just initially, so you can see what their blood pressure is at that visit, but also look at the ones you've taken in the past to just kind of see how they're trending, making sure if they're on high blood pressure medicine that is effectively lowering their blood pressure, just to make sure that everything's working and make sure they're not declining in their health. So some common disease processes that are found in the cardiovascular system in older adults. The first one is the most common one, which is hypertension. There is many cases. Many older people have hypertension. In fact, elder people are more likely to have a higher systolic reading than the diastolic, so that's something to look out for as well. And also to diagnose that, it's 140 millimeters of mercury for the systolic and 90 millimeters of mercury for the diastolic. So 2 consecutive readings of that at different times is enough to diagnose somebody with hypertension. However, as stated on the slide, recently a reading of 150 millimeters of mercury can be acceptable for those 65 years of age, just due to as you age, your blood pressure naturally tends to go up slightly. But after age 60, it generally levels off. kind of staying where it's at, and it'll generally stay and won't increase anymore after 60th birthday. Also, in its most basic terms, hypertension is increased when either cardiac output or systemic vascular resistance are raised. So this can be due to any kind of factor, such as the heart having to work harder to pump blood, or the vascular resistance through plaque buildup and any kind of buildup in the arteries that can cause the blood to not flow as efficiently through there as it did before. So these are some modifiable risk factors, which is alcohol and tobacco use, obesity, sedentary lifestyle, stress. And a lot of those factors, those can cause the buildup of the plaque and on the arteries and cause the heart to work a lot harder through their life, which will tire it out and can cause hypertension. Another one is heart disease. So that's a very common problem. Many elder people have heart disease. It's often caused by atherosclerosis. So that's basically when elevated cholesterol levels throughout their life have caused plaque to build up on their arteries, causing their blood on their heart arteries, the arteries that supply blood to the heart. So therefore, less blood going to the heart, less oxygen being supplied, and causing tissue death over time. And also hypertension plays a role through this with causing heart disease, because the heart has to push harder against the resistance, causing it to work a lot harder throughout their lives. Also, big thing with heart disease is myocardial infarction. So that occurs whenever there's a blockage of a vessel on the heart that's supplying blood to the heart. So that loss of oxygen begins to cause quick tissue death, which causes the heart to not function efficiently. And also, the way MIs manifest themselves in elder adults can be a lot different. Whereas in younger adults, it can be left arm pain, jaw pain, chest pain. But older adults, it can often be like nausea, fatigue, really just non-specific things that can be easily missed as a heart problem. And also, they can experience silent MIs. So this is when they are having a heart attack with no symptoms, which is obviously a huge deal because the heart muscle is dying and they don't know what's going on, so they can't get treated for it. And the last one is atrial fibrillation. So that's just basically the rapid and irregular heartbeat that causes blood to not be pumped as efficiently throughout the body. It can be a normal pattern or irregular for the patient. It may occur once, intermittently, or it might be a persistent thing. And it often occurs more in older adults, especially white older adults. Generally, the age to be diagnosed with it is men that are 67 or older, generally can be diagnosed, and women that are 75 and older is when it's generally diagnosed in these patients. And causes of atrial fibrillation, sometimes it can be on its own, but oftentimes it's due to heart failure, diabetes, alcohol abuse, hypertension, but oftentimes it can be found on its own too with no underlying disease process causing it. As stated before, it's often a complication of another disease, however it might not be, might be from some undiagnosed reason. It also can be asymptomatic, so they might have atrial fibrillation for a lot of their life and never really know it. And a lot of times, even if they do have symptoms, they're really nonspecific, such as fatigue or just being tired, not really attributing that to any kind of heart problem. But the most serious risk with atrial fibrillation is the risk of pooling of blood in the atria. So if that happens, then there can be clots build up in the heart, and once the heart goes back into normal rhythm and begins pumping blood more efficiently after the episode of the atrial fibrillation, if they have intermittent or unless it's persistent, that can cause those clots to begin being pumped out into the body, which can lead to a multitude of problems, being a clot getting stuck in the heart, arteries, or just anywhere in the body, causing an embolism, especially the brain. A big one is stroke risk for these patients. They can have a stroke because of the clots that are building up in their body or in their heart. And obviously that's a big problem and serious medical problem that needs to be treated quickly. So some education to give to these patients is, for one, the importance of monitoring their blood pressure at home. That's a really important deal because it allows them to see what their normal is and monitor it. That way they can know when maybe their blood pressure medicine's not working great, or if they don't have any high blood pressure, they can begin to see a trend of that they're having high readings, and just kind of let them know where their health is at. And it helps healthcare professionals too to have that data to back up with what they're seeing currently whenever they go into the clinic. Also, just let them know what warning signs of imminent heart attack are, or any other kind of cardiovascular event. Since they're non-specific symptoms, it's good to let them know that it's not always going to be just chest pain. It's not going to be always incredibly obvious, so let them know some of the more subtle ones to look out for. Also, risky behaviors such as, like we talked about earlier, tobacco use, alcohol, just being with obesity, sedentary lifestyle, maybe try to cut out some of those things and help them with that. Gives them some teaching of how to not partake in those anymore, and maybe get in touch with a dietitian for their diet and everything. Also, so it's important to let them know to be cautious when exercising. If this is somebody who exercises every once in a while, maybe goes for a run, let them know to be careful, because if their heart's not pumping as efficiently anymore, then their body's not going to be able to hold up to the same oxygen demands that they used to put on it, because their body won't be able to supply it, or their heart won't be able to supply it to their body. And also, finally, the signs and symptoms of stroke. And this really applies a lot to the atrial fibrillation patients, and also to all the other patients too. But importantly to them, just let them know what to look for, or their spouse or caretaker or family, just anybody. Let them know facial drooping, just slurred speech, just looking tired, any kind of symptoms and signs, just because as quickly as they can figure out they're having a stroke and get them to the hospital, the better their outlook is. So here's the references that I used. It was the assessment book from freshman year, our med-surg book, and the gerontology book, and that is all for my PowerPoint.